Right. Now we need to consider questions relating to drug metabolism in clinical pharmacology. I'll introduce the first question. People can be described as either fast or slow drug acetylators. Which of the following statements is true? And I'll leave you some time to consider that. Coming to the answer, I think a little bit of background is important. When we talk about metabolism, we talk of either phase 1 or phase 2. Phase 1 is the redox reaction, reduction oxidation, and that's mainly done in the liver by the cytochrome P450 enzymes. Phase 2 is really about making them waterphilic so that they can be hydrophilic, they can be excreted by the kidneys, and several processes will occur. So phase 2 will have either glucuronidation, acetylation, amino acid synthesis, methylation, sulfate addition, and others such as glutathione, which are important for paracetamol. This question is asking about acetylation. So in those patients who are slow acetylators as opposed to those who are fast acetylators. So when we go to consider the answers, which of the following statements are true? Sulfasalazine can cause hemolysis in slow acetylators, and that's what it does. In those patients who are unable, because they're slow at acetylating it, unable to metabolize sulfasalazine, it will cause hemolysis. Slow acetylation is an autosomal recessive trait. Interesting, 60% of Japanese people are fast acetylators. It's actually 60% of Caucasians. In the Japanese population, it's actually less than that. It's about 10 to 30% who are slow acetylators. Drug acetylation from the slide before is a phase 2 reaction. Dapsone treatment can cause neuropathy in slow acetylators. That's a tricky question because dapsone is affected in slow acetylators, but it doesn't cause neuropathy, it causes hemolysis. So dapsone and sulfasalazine cause hemolysis in slow acetylators. Let us now consider question 2 on metabolism. You are reviewing a patient in an outpatient clinic and you notice that he has previously been shown to be cytochrome P450 2D6 isoenzyme slow metabolizer, that's 2D6. Which of the following drugs will have its metabolism altered and would therefore have increased unwanted effects in this patient? Consider these drugs. Here, I will focus on the cytochrome P450 enzymes which are involved in the metabolism phase 1 of the redox oxidation reaction. 3A4 being the majority of the isoenzymes. The next after that are 2D6 and 2C. 3A4 will be the majority of drugs. 2D6 will have drugs such as beta blockers, which is the correct answers, tricyclics, codeine, ecstasy, which is MMDA, as its main metabolite. Barbiturates, diazepam, and dapsone are not 2D6. 2C8 is a metabolizer of omeprazole, and 2C9 is a metabolizer of warfarin, which is not there. Those are the important isoenzymes and their substrates. We will go on to question 3. Which of the following drugs is an inhibitor of cytochrome P450 isoenzymes? And I have this list to consider. This is very important for the exams since most of the questions pertaining to metabolism are to do with inhibition or induction of enzymes. Just to explain inhibition, and I'll explain it in a way so that you can remember it. The easiest way to remember it is that inhibitors inhibit the breakdown of drugs. So, for example, if I was to take warfarin, which can cause bleeding in high doses, if I take an inhibitor, it will inhibit the breakdown of warfarin and lead to more bleeding. And that's what the question is asking. Which enzyme is an inhibitor of the P450? And in this case, it's sodium valproate. Rifampicin, barbiturates, and carbamazepine I'm about to discuss in another question. But let's look at enzyme inhibitors. And for the exams, there's a nice simple mnemonic you can remember, which is O devices. O for omeprazole, disulfiram, which is an antabuse, erythromycin, valproate, isoniazid, ciprofloxacin, cimetidine, and ethanol. Ethanol here is acute ethanol, so what medical students do when they get drunk acutely. Sulfonamides, allopurinol, and fluconazole. All these inhibit the clearance of other drugs. We will now move on to question 4. A 27-year-old Asian man on anti-tuberculous therapy complains of tingling and numbness in his hands and feet. Which anti-tubercular drug may be causing this problem? This is a very important question. It combines a lot of aspects of metabolism because it talks about genetic polymorphisms, slow acetylators, fast acetylators, and also inhibition of enzymes. There is only one correct answer, and I'll leave you some time to consider that. In this case, the answer is isoniazid. It has a lovely structure, which you do not need to know for the exams, but isoniazid in slow acetylators will cause peripheral neuropathy. It is also an inhibitor of P450. Question number 5. A 29-year-old woman on antituberculous treatment with rifampicin, isoniazid, pyrazinamide, and ethambutol, the standard treatment, and pyridoxine has been taking the oral contraceptive pill, but suddenly finds she's pregnant. Which drug would have resulted in failure of the oral contraceptive? Please consider these. Let's look at the answer. I think this is a very important question, clearly leading to, from taking treatment, she has failed in her contraceptive. This is because of induction, and the way to remember again is that inducers induce the breakdown of the other drug. So she has taken a drug that has led to the breakdown of the contraceptive pill, and hence she has become pregnant. It has failed to work. The way they do that is they increase the amount of cytochrome P450. And so with increased amount of P450, you have increased breakdown and metabolism of the second drug. And in this case, the most potent inducer that we know is rifampicin. I told you that I would come back to inducers because many of the questions pertain to induction and inhibition. So let's look at the enzyme inducers. The most potent is rifampicin. And here to remember that many of the antiepileptics, so phenytoin, carbamazepine, and barbiturates are all inducers. Remember that one exception, which was valproate in the previous question. Not all antiepileptics are inducers. Valproate is an inhibitor. Here, alcohol. This is different. This is the chronic alcoholics, not the medical students. These are the guys out in the streets who are hitting the bottle really hard. Chronic alcohol, as opposed to acute alcohol, does the opposite. It is an induction. And interesting, cigarette smoking causes induction of your enzymes. So potentially, if you smoke, the pill won't work. Let's go on to question number 6 in metabolism. Here we have a 58-year-old man who presents to clinic with easy bruising and bleeding from his gums. He has a history of diabetes and has recently been prescribed medication for neuropathy. In addition, he has an infection, but he can't remember which antibiotic his doctor has recently started. Chronic medication include warfarin for his atrial fibrillation because he failed to cardiovert. His INR is normally stabilized at around 2.1, but recently it has increased to 5.0. Which of the following medications is most likely to be responsible for the recent disturbance in coagulation? And we have 5 drugs here to consider. You will see the result of what happens if you do not consider this drug interaction. In the corner there, you will see an image of someone who has had an INR that's shot right up and has bled into their leg. And that has led to necrosis and unfortunately can lead to amputation of the leg. So care must be given when answering questions. Care must be given when considering this in clinical practice. There is only one answer, and that is A, ciprofloxacin. The mechanism of it is interesting. So ciprofloxacin is an enzyme inhibitor. It inhibits cytochrome P450 2C9. And you'll remember 2C9 is a metabolizer of warfarin. So Cipro has inhibited the clearance of warfarin. Hence, the INR has shot up and the patient has bled. Clarithromycin is also an inhibitor, but not of 2C9. Trick question. It is of 3A4, and I think we'll consider it later. Rifampicin and carbamazepine, these are inducers and would not lead to this problem. If anything, they would lead to the converse. And this image just shows more clearly what happens when a patient who is on warfarin and you do not consider the induction and you give antibiotics such as ciprofloxacin, the effect, severe bleeding, necrosis, and ultimately amputation, and possibly you could be sued. Let's consider the next question. A 67-year-old man presents with weakness and muscle aches. He has a history of hypertension and dyslipidemia and is managed on ramipril and simvastatin. He also has COPD and is treated with high-dose seretide inhalers. You understand that he was started by his GP on antibiotics a few days earlier for a lower respiratory tract infection, and he has the following biochemistry and full blood count. So he has a normal HB white cell count and platelets, sodium 141, potassium 5.9, creatinine 190, and a creatinine kinase of 890. Which of the following is the antibiotic he is most likely to have been prescribed? I would like you to consider these antibiotics. The answer is clarithromycin, but I think the most important thing here is to go back and to look at the indices there. What you have noticed is that his CK is highly elevated and his renal function has also gone off. What he has developed is rhabdomyolysis. The drug that he is on, which has interacted with clarithromycin, is simvastatin. We know that statins will cause rhabdomyolysis if the statin levels are high. Clarithromycin is an inhibitor of cytochrome 3A4. It has inhibited the breakdown of simvastatin, and therefore we have got simvastatin-related rhabdomyolysis. Cipro is the only other inhibitor on that list, but it is not an inhibitor of 3A4, but rather of 2C. Let's consider the next question. A 64-year-old man presents to the A&E complaining of muscle aches and tenderness. He has a previous history of myocardial infarction and takes a number of drugs, including simvastatin. Recently, he has made a number of changes to his diet, and he has tried to improve his health. Plasma CK is elevated at 4,800, and you suspect rhabdomyolysis. Which of the following interactions with simvastatin is most likely to be responsible for this presentation? Rather than drugs which have interacted with simvastatin, I would like you to consider these over-the-counter medications which do not require prescriptions and are not necessarily drugs which can interact with simvastatin to cause rhabdomyolysis. Please consider these. This is very important because obviously we're not prescribing these drugs, but as doctors, we should be able to advise patients about what to avoid and to be aware of the interactions which are clinically relevant. St. John's wort, easily bought in any shop, but it's actually an inducer, so it would lead to the breakdown of drugs, like rifampicin would. Cranberry juice, that's interesting. It is an inhibitor of 2C9. So in this case, cranberry juice would potentiate the effects of warfarin. So we tell patients who are taking warfarin, do not drink cranberry juice. On the other hand, grapefruit juice is an inhibitor of 3A4. So it is responsible in this case for the interaction with simvastatin. Grapefruit juice has inhibited the breakdown of simvastatin and has led to rhabdomyolysis. Vitamin C and cod liver oil are safe. They do not have any interaction with the P450, so we can tell the patients go ahead with those. We have looked at questions pertaining to drug metabolism in clinical pharmacology. We will now move on to look at drug treatment specifically. Thank you.